Welcome, welcome everybody. Thank you. Thank you so much for joining. 3 o'clock. Okay, so I am going to get started. I know people are going to continue to come in. We're clicking people in from the waiting room or whatever, the Zoom room or whatever we're calling it. Thank you so much for joining us for the Finger Lakes, New York State 1115 waiver overview. This has been a long time coming. I'm really excited to share what we know and what we don't know also. So I'm going to put that caveat out front that there's a lot that we still don't know. So welcome on behalf of Common Ground Health, FLIPS, Finger Lakes Performing Provider System, and Rochester Rio. I welcome everybody. We have everybody kind of on camera now just because I love to see faces, but now we're 3 pages, 4 pages over. So I at least want to say hello and thank you again for coming. So go ahead, Tommy, let's cameras off and you can leave, which I can't stand. I'm really sorry about that because I want to see everybody, but we got to do the Zoom thing. So the webinar thing, the official webinar thing. So everybody is going to be muted and your videos will be turned off or whatever, not sure whatever Tommy's calling it. And we will leave me and Wade and Teresa from Rochester Rio on the screen. So whenever Tommy's ready to do that, he will do that. And there it is. Okay. There's the slide deck, which of course will be shared. And somebody's going to give me the signal for when the videos are off and I can proceed with Wade and me and Teresa on deck. All right, well, while they're trying to figure that out, welcome everybody and Happy New Year. Jerome Underwood said to me this week that I can still say Happy New Year because it's not February yet. So apparently I can still say that all throughout January since we haven't seen each other. Many of us haven't seen each other yet in January. So Happy New Year, happy waiver, I'm hoping finally. We have 277 registrants and participants today, so that's really exciting. It does show a level of interest in the waiver. I'm hoping today's going to be valuable, and I want to thank my colleagues here, Wade Norwood from Common Ground Health and Teresa Mullaney from the Rochester Rio, who is standing in for Marlene Bissett, who I'm sure has some state New York nice function that she has to participate in. So Teresa is going to help us with some Rio content today. I also just want to shout out to everybody who helped put this thing together. I'm not going to say last names, Courtney, Janet, Albert, Thomas, Tommy, and everyone else who participated in the background and trying to put this thing together. I also want to thank you for hanging in there with us as New York State finally got their approval, and also for reaching out, asking great questions, and really just staying engaged. I just love our region. The Finger Lakes region is just like no other. We're hanging together, and it's just a really exciting time. I am going to hand it over to Wade for a few comments, and then I will take it from there with some housekeeping, and then we will dive right in. We have a lot of slides today, a lot of content, so grab your coffee and hang on. I'm going to talk fast like I usually do. You will, of course, get slides, but it's going to be a lot of content today, so I'm forewarning you. Okay, Wade.
Carol, thank you. And friends, I've got 6 little tiny Post-its. The first is to say thank you for your patience and continued engagement in this process. Carol already did that, so I say thank you to my excellent partner. And I will then say Happy New Year to those I have not seen yet, which Carol did, but add in my own Wade Norwood way, those of you who I have not given a 2024 hug to, I look forward to the opportunity. Incredibly excited to be here is posted number 2. It's taken us a long time to get here. And I hope that you are really appreciative of why we have tried in the journey to not engage in shadow boxing over specific proposed elements, but rather to have waited until we actually have the details of a waiver proposal in front of us. And I thought Carol was going to say, when she said 277 people, I thought she was going to say 277 slides, because she has been a maven in dissecting and interpreting this. And I know that I benefited from it and have shared this content at a national level. And the excitement of sharing this continues to affirm, my friends, with the CMS approval letter and an actual governor's proposed budget. I declare we have now reached the final scene of Moonstruck. And if you all remember the movie, I just think it stands out as a movie that 95% of which was complete chaos. But the 5% of the kitchen scene, everything made sense and everything came together. I honestly believe all of the anxiety and pressure that we're about to experience and are experiencing is really because of the fact that everything we've been working on together for the last 25 years is coming to fruition. I am really excited about this moment. And I am reminded that when he left Robbins Island, Nelson Mandela was interviewed and he said it is the job of leadership to call people to rise above their petty preoccupations. I want to thank you all for being leaders in this community and all that you have done to get us ready for this moment where we can rise above the small preoccupations of healthcare delivery to really be focused on healing and on health and on equity. So, Carol, I'll stop talking and hand it over to you, dear friend.
All right. Thank you so much, Wade. Always inspiring us and lifting us up, even on this dreary 3 o'clock afternoon. Apologies if you hear a jackhammer in the background. Of course, there has to be jackhammering going on in, right outside the building. But the good news is over here on the corner of Broad and Main, they are building affordable housing. So that's, I suppose, a good sign. Okay, so let's dive in here. Housekeeping items. Keep your lines muted. Thank you for that. The presentation slides will be posted on the website, the Finger Lakes 1115 Waiver website by next week, or by tomorrow, actually. No, by tomorrow. The webinar recording will be posted by next week. Apparently, it takes a while for that to get generated, so we'll be sure to get that posted. We're going to try to do the Q&A for the questions. So feel free to jump in, put questions in the Q&A. Janet King and Albert are monitoring, Albert Blankley from Common Ground Health and Janet King from Flips are monitoring it. Janet, I know for a fact, has the waiver open and has the Social Care Network RFA open. So she'll be able to, look up things very quickly. If not, we will keep a track of all the questions, and we will put them together with whatever FAQ that New York State puts out, and we'll provide that for everybody on the website. Okay, let's move ahead. Our agenda is we're going to do an overview. Some of you will have already heard a lot of that content if you were on the Council of Agency Executives call 2 days after the waiver dropped on January 9th. That content was 48 hours old. So we have included that as well as refined it and updated it. And then we've added additional content given that we now have the Social Care Network RFA. So we'll talk about the main components of the waiver. I'll have Teresa go through the Rochester Rio and the Shiny role, because that's a very, very important piece of this waiver. I'll go through the health-related social needs and the social care network overview. And then we'll talk a little bit about how you can prepare, not too different than what we've talked about before on how you can prepare. We just have more details now, and we'll go through as much as we can. And never fear, the information will be out there. We will also continue to do webinars to refine and kind of deep dive as necessary, and maybe even do targeted information sessions for particular sectors. So we'll decide all that. Then we'll go through next steps, what the timing of things are, and we have a slide on the resources, the website, and the newsletter. Okay, so let's start with the overview. Recap first. So CMS approved the 1115 waiver amendment on January 9th. As you know, there's an 1115 waiver that's been going on for 25 years related to Medicaid managed care. This is a waiver amendment, just like DSRIP was a waiver amendment. This is a waiver amendment. That was January 9th. The Social Care Network RFA was released on January 16th. The period is going to be 3 years, so consistent with what we thought. We lost a lot of time, frankly, going back and forth with the Trump administration originally, and then with CMS. So we are at 3 years. Hopefully there'll be a 2-year extension that New York State would go after. So the waiver period starts 4/1, goes through 2027. The amount is $6.7 billion. I'm not too concerned about that dollar amount. Of course, we would have liked that dollar amount to be a lot more. You recall that the first draft was like 17 billion, and then it was 13.2 billion was the later draft. 6.7 billion, it's at least what we need. So that's a good sign. The goals overall have remained the same. This is about advancing health equity, reducing health disparities, and very importantly, supporting the delivery of health-related social needs and promoting workforce development, which is really, really key because that was not included in what CMS was looking for. And New York State fought for that. They had the regions behind them. And that's an example of how advocacy works. They heard loud and clear that the workforce is a challenge, and we were able to have CMS approve the workforce component of this. Okay, waiver overview. Just kind of going back in time, just a little bit to ground us on what the $13.52 billion version of this was versus what we finally have approval. This is literally a negotiation process that CMS and New York State went through. So the original dollar amount was 13.52. The later draft, we're down to 6.7 billion. The original had regional heroes, health equity reform organizations. The original had social determinants of health networks, which really are called social care networks now. The original had a lot of detail around investments in advanced VBP. This focuses more on the hero, talking about developing VBP model. Capacity building and training, luckily, is still in this. It's through the social care networks. Ensuring access to criminal justice involved populations, that was pulled out by CMS, and CMS said you can do that outside of the waiver. Transitional housing service and alternative for homeless and long-term care, that is kind of embedded in the health-related social needs piece. The COVID unwind, gone. Development of workforce is in here. Obviously, they would have scoped it smaller, and creating digital health and telehealth infrastructure at a statewide level is now not a requirement. They are now allowing that at the regional level. So high level HERO, what we have now is HERO, HRSNs, and social care networks. There is a Medicaid hospital global budget initiative. Downstate only is in red on purpose because we are left out, and that is concerning to many upstate partners. So I have that in red as a potential point of advocacy as we think about public comment. Strengthen workforce is in, and what's new is focus on substance use disorder amendment and alignment to CMMI alternative payment models. All right, next slide. So that kind of grounds up. I wanted to start out with a money slide, which always is usually at the end, but wanted to get your attention and give you some context. All right, so this is our slide. This is my slide. So hopefully the numbers are right. I think we've checked it 100 times. So $6.7 billion. Let's start on the left. The gray area is the Medicaid hospital budget, global budget, downstate only, again in red. That's a big chunk of change, $2 billion dedicated to a couple of counties. I think it's 4 counties downstate to shore up their struggling hospitals. And so we're not going to discuss it, but I do want to point it out, given that upstate was not included in that. We have workforce then kind of at the upper left-hand corner, the purple and the pink. Student loan repayment, career pathways training make up 10% plus of the total budget. 2 sections to the workforce piece. So I'm very pleased to see that they kept workforce in. As far as the statewide hero, like I said, they've moved from regional to state. It will be a statewide health equity regional organization. There's a slice of dollars, $125 million for the hero funding at the state level. And then the blues. The blues are HRSN services, 47.4%, and infrastructure, $500 million. Okay. I do have an asterisk in here, not really sure exactly about state dollar match requirements. That's kind of technical stuff on the other side. The other thing that I want to let you know, as I talk through this, I might mention things that are like outside of the waiver and are in the state budget. This is not a dive into the state budget at all. I know that there's a whole bunch of talk around that. I am going to, in the future, create another slide that looks like this, except it puts this on the left, and on the right, we're going to kind of have the state budget elements that relate to the waiver amendment. Okay, so just that, we're going to be on the lookout for that, because I think that'll help describe a little bit more how the waiver is connected to the state budget, which is a new approach. The governor has connected the waiver to the state budget. The waiver is a demonstration project, and the state budget kind of is over here, but she has connected them. So we're going to have to do a little work kind of crosswalking things so that it's less confusing. Okay. All right, next slide is a waiver funding timeline. All right, so these are the categories on the left that were in the pie. Okay, and here are the timing columns. So we have 1/9/24 to 3/31/24. Then we have the next year, which starts 4/1/24 to 3/1/25, etc. Okay, through 27. You're going to notice the use of DY, demonstration year. And you're going to notice it says 25, 26, 27, and 28. What the heck? If you recall, when we did DSRIP, they were using DY0, DY1, 2, 3, 4, 5, DY5. DY5 was the last year of DSRIP. It appears that they have chosen to label each of these years DY25, 26, 27, 28 in reference to the original 1115 waiver in 1997, when the original 1115 waiver was created for the purposes of developing the Medicaid managed care approach to services and enrolling Medicaid people into the managed care entities, the Medicaid lives. That was 25 years ago, so they are calling this DY25. All right, so it took a little bit to understand that, but just if you're confused as to, what do these numbers mean? That's what that means. All right, so let's look at the columns. So the first year, or actually pre-first year, what we used to call in the old days DY0, okay? DY25, there will only be funding of the $2.2 billion for the hospitals downstate in those counties. There will be some upfront dollars before the budget starts, the state budget. Then you can see how the dollars flow, kind of a little bit front loaded. And you can kind of see even for the downstate hospitals, and then kind of various kind of flows up and down for the other categories. All right, so there's your $6.7 billion and an idea of how the dollars flow over the course of the 3 years. All right, now we're going to look at the timeline for implementation. Again, with these DY 25s to DY 28. So waiver approved, Social Care Network RFA released. The Social Care Network RFA is due March 27th. We'll talk about which organizations could be eligible to apply. There's a lot of activity going on in our region for potential collaboration with a couple of lead agencies yet to be determined very quickly in short order. But that is due March 27th, so it's a very, very fast turnaround time. And then there will be other procurements in place, potentially for the HERO, et cetera. So then we start off running. The contract for Social Care Network starts August 1st. The waiver has an interim evaluation due the following year. And then the final waiver amendment year is 3 years in. It's very quick. And then the question is, will they submit for a renewal, likely for two more years? The concept is that things will start to shift toward risk-based programming under Medicaid managed care to really start to incorporate the health-related social needs into value-based payment arrangements that primary care entities are in, primary care IPAs, for example. And so that will be the shift. It is likely that the health-related social needs aspect of it will remain on a fee-for-service basis for a while, anyway, for a while. Okay? Now, normally I'm able to look at you with your nodding heads, so please move things into the Q&A. I'm sure I will get a text if somebody, if I'm like going too fast or too slow. All right, now we're gonna move into the main components of the waiver. And again, apologies to those who've already heard a lot of this at the COAE. Main components, health-related social needs and social care networks. I have now said that 100 times, and we're only this many slides in. So that is the core of this whole waiver, because that speaks to health equity, addressing the population's health-related social needs. And if you recall, we talked about early on this notion of social determinants of health, and I had said the state is starting to use the words health-related social needs instead because it's more of a clinical focus. Okay, we were a little worried about that. And so that is how CMS is looking at this. They are tying this to clinical and to diagnoses, but it starts out with general screening of all the Medicaid population. So that's a good thing. All right, the statewide HERO is an element, workforce, again, the downstate investments, and then other waiver priorities. All right, health-related social needs and social care networks. Let's do a quick kind of overview, and we're going to do a deep dive in a bit. All health-related social needs must be, and this is a quote, clinically appropriate and have a reasonable expectation of improving or maintaining the beneficiary's health. And this is what I mean by a little bit clinically focused. Okay, there will need to be a tie to confirm your speaking language. I think I'm having a note here that it doesn't sound like they think I'm speaking English. Okay, somebody will tell me if they can't understand what I'm saying. Clinically appropriate and have a reasonable expectation. So there is a tie to clinical, that the health-related social need, housing, transportation, whatever, is directly connected to a particular diagnosis, diabetes, etc. All services are optional for the member. So just like in DSRIP, there is an opt-out provision for members, Medicaid members. Managed at a very high level, managed care organizations, managed care plans, MCOs, so I'm going to say MCOs probably from now on, will contract with social care networks of CBOs to organize and deliver health-related social needs services. MCOs are going to pay, so the state is going to pay the MCOs, the blues, right? Remember the blue, the dark blue, will pay the social care network lead entities for health-related social needs screening and enhanced services. And it's going to be based on a PMPM per member per month to the social care network. They're going to reconcile on the back end based on actual cost. And then the social care network is going to pay the CBO's state set rate. And that's going to be tailored by region for those services. Okay. There will be pre-qualifying, right? So you've got to go back to the top, clinically appropriate, and have a reasonable expectation. That needs to be much more defined. We're digging into that, but that's got to be more defined. What's the definition of a CBO? I wanted to make sure that's pulled out. Not-for-profit charitable organization that works at the local level to meet community needs and is registered as a 501c3. We will probably need to do a little bit more of a deep dive into what exactly does that mean. Okay. All right, let's move on to, now we're still talking high-level waiver components. Statewide HERO can be a contracted entity designed to develop regionally focused approaches, which is to me a little bit interesting that it's a statewide HERO that's going to do regionally focused approaches, but that's okay. To reduce health disparities, advance health equity, and support the delivery of health-related social needs. They're going to coordinate data. So all the things that are in here are the same things that the original HERO, the regional HERO that we talked about before, will need to do. They will need to coordinate the data between the social care networks, the workforce investment organizations, the SHINY. We're going to hear from Teresa about the SHINY, to assess and address the healthcare quality and equity outcomes. The whole point of this is to identify disparities and address health equity and improve health outcomes. The HERO has to be independent from the state or other government agencies, so that's interesting. And it's likely that's going to be a procurement process. Don't know if it's going to be a consultant, don't know if it's going to be some kind of a coalition. I don't know. We don't know that yet. Okay, the next slide, I'm not going to go through in detail, but these are the responsibilities of the HERO that we've talked about this before. Data aggregation, community needs assessment, stakeholder engagement, VBP planning, and publishing health equity data. And you can see the detail. This is not that much different than what we talked about before that the regional HEROs would have done. Now, what I'm hoping, now I'm going to throw in a few Carol opinions. So apologies to anyone who is here just for facts. It's 95% facts. My opinion is that I'm hoping the statewide HERO is going to have strong representation from each region, which means we're hoping that we're going to be represented, of course, on that HERO entity board, whatever it's going to be. Okay, I'm going to kick it over to Teresa. So this is going to get technical. So get an extra sip of coffee for this. We've got a few slides, and then Teresa's going to send it back to me. All right, Teresa, you can unmute. Hopefully they'll let you do that.
Oh, I just got unmuted. Here we are. Okay. Thank you. Thank you, Carol, and thanks for the opportunity to present. Carol's going to talk more about the specifics of a social care network, and I just wanted to highlight some of the things that are explained in the RFA for the requirements of a social care network that might be new language, specifically related to SHINY and data exchange. So first, kind of what is SHINY? It's an acronym I learned once I joined the RIO. It's the Statewide Health Information Network of New York. It facilitates the secure electronic exchange of patient health information and connects healthcare professionals statewide. It's comprised of our 6 regional QEs, the Rochester RIO being one of them. And our region, our geographic region and 14 county makeup overlaps with the Waiver region of the Finger Lakes. The purpose of health information exchange and of a QE in partnership with our other QEs as members in the SHINY is to enable collaboration and coordination of care to improve patient outcomes, reduce unnecessary and avoidable tests and procedures, and ultimately lower costs. We're connected through the SHINY to 100% of the hospitals in New York State and over 100,000 healthcare professionals. It also represents millions of people living in and receiving care in New York. The SHINY has a central role in enabling the health-related social need data exchange and analysis for New York State. The state really wanted a better pulse on the data in this waiver than in the previous waiver, and they're leveraging the SHINY to do that. So the QEs have a similar role to play in facilitating this secure exchange as we do in healthcare. For the appropriate access of health-related social need. where appropriate. So the state is requiring that every social care network connects to the Shiny, right, the regional QEs, and develop bi-directional sharing with their regional QE using the Shiny to facilitate appropriate access to health-related social needs that also might be within or outside of a social care network. So what is enabled through the Shiny is data exchange to our other regions. So the Rochester Rio, we facilitate the data exchange within our region, and through partnerships, and the Shiny can connect to our other QEs to get access to the appropriate data. It also is a requirement that social care networks should develop a data sharing relationship with MCOs to exchange eligibility and other fiscal administration data, and that the state envisions that the health-related social need data will be codified and shared according to common standards. Those are still in development at the national level. And what's specified also in the RFA is that social care networks will participate in a statewide work group of Shiny stakeholders, including the QEs. So we currently meet bi-weekly. We've been meeting for the past year around codifying and ingesting health-related social needs to get ready. So we welcome that addition to that work group. And it also may integrate with efforts with national public-private initiatives similar to the Project Gravity and open referral standards to make sure that New York State is aligned with those standards. So just to reiterate, the Rochester Rio is the Finger Lakes Regional QE and is a Shiny member. And we've been preparing for the waiver to drop, so we're excited about that. On the next slide is the graphic that's provided in the RFA around the data flow. We're going to work for our education materials on something a little bit more colorful, but just to articulate the connections that the social care network would be required to make and how it relates to the Shiny, and also getting access to other data either within or outside of a social care network to ensure that for patients that travel across borders, we can still have that appropriate access of data. So in further, if desired further explanation around the specifics to this information, we can provide. But this is the general flow of the data flow that we've been preparing for. And you'll see on here, just as a highlight, right, the MCOs, healthcare providers, social care network, the qualified entities, and then an acronym, I guess I haven't explained yet, is the New York eHealth Collaborative, is really an office. I conceptualize an office of the Department of Health that helps organize the Shiny efforts. So on the next slide is just specified of what the awarded lead entity will be required to do in terms of data exchange. And the reason why I wanted to explain this, the technical components before we get into the meat of the rest of the waiver, is to just share that this might be new and unfamiliar in terms of social care space, but that we have been preparing for this work as the QE, as also as part of the Shiny for the past year. So just to highlight, we're ready to enable these specific requirements in partnership. So first is, ensuring that there's a DUA in place with the regional QE to ensure that the QE submits data on behalf of the social care network to the Shiny Data Lake, Data Lake is just a repository of data that the state can then access for their reporting and analysis. In coordination with the QE, obtain data from the Shiny in a timely manner, so passing data from other regions when needed, to ensure that the social care network IT platform can pre-populate information from the Shiny into the user interface, like member or eligibility information that we would be getting from the state directly and sharing with the social care network, and adopt terminology and coding standards for billing, for analysis, like ICD-10 codes, Z codes, CPT codes, SNOMED codes, right? This is the language of the Rochester Rio. So it will soon be the language with social care networks, and also to ensure, again, that there's a way to submit for payment to MCOs, attest to agree to share this information with the QE, meet HL7 FIRE National, it's another acronym, standard for bidirectional information, which just means the data is formatted in a way that is easy to share. Getting to the standards is not necessarily easy, but once we're there, it's easier to share. And define an approach and align data quality standards in a validation process with existing federal and state standards currently used by QE. So we do a lot of data quality work on making sure that the data that we do report to the state when necessary is of high quality and across our partners. So on the next slide is just, an offering that if anything in the RFA is unfamiliar or unclear about the data exchange requirements, the technical components of what is expected of a CNA, and you're interested to learn more, please reach out. Happy to answer any questions that we can. And also the state is always an option there for questions. And just to share that as we have prepared for the waiver, the RIO has worked towards meeting national HL7 fire standards in terms of getting our data ready for this exchange. We, as I mentioned, active membership in this state or in the statewide group around readiness, exploring data exchange capabilities with some partners historically that the RIO wasn't able to connect with, like CBO partners. And expanding our clinical query portal, which some of you may be familiar and know as Explore Plus, in order to have social care providers have access as authorized by patient consent throughout the waiver. So that's all I wanted to review. Thank you, Carol, for the time, and I appreciate your time and attention.
Okay, thank you, Teresa. That was very efficient. Great information. And just to reiterate, the RIOs across the state are going to be really important and central to this waiver. If you're thinking about how the RIOs operate with health data exchange, right? We're so used to it, right? You get your lab drawn and all of a sudden, the doctor has access to it. This is the same thing that we want for social care data, for health-related social needs, food insecurity, et cetera. We want that data to be able to be exchanged so that the providers can provide the best care and the appropriate referrals, okay? So it's really important. All right, let's move on to workforce investments. So very excited that the state was able to convince CMS for these investments. It's a little targeted, so we just have to understand what the scope is. And the scope is certain healthcare practitioners who serve Medicaid and demonstration beneficiaries. So there's two initiatives: student loan repayment for qualified providers and career pathways training program. And the idea is that these initiatives will target workforce shortages for particular targeted workforce titles who theoretically support the delivery of health-related social needs and increase access to culturally appropriate services. Now, the one thing I do want to say is that there's not, in my opinion, just like I said in the last couple of iterations of webinars, I don't believe there's enough focus on the words health equity and those kinds of things and what is the accountability around health equity. I'm hoping we're going to see more about that in the outcomes that are going to be required to be achieved. So we'll be talking much more about that on how is that health equity accountability going to happen in this waiver. But you will see the importance of culturally appropriate services and approaches to care. Okay, so next slide is, we're going to do one slide on each of these initiatives real quick. Loan repayment, again, for certain healthcare workforce shortage professions, and the professions are listed here, who make a 4-year full-time work commitment to a practice panel that includes at least 30% Medicaid and or uninsured members. So you kind of have to think about, well, obviously if you're on this webinar, you are probably serving a lot of Medicaid lives. And so 30% is the threshold to qualify for this. Psychiatrists with a priority on child adolescent. There needs to be the maintenance of a personal practice, so their own practice or part of an organization that has a practice. Again, that 30% mark. Primary care physicians and dentists, yay for primary care. Finally, up to $100,000 per provider for loan repayment. Again, personal practice panel or working at an organization, at least 30% is the cutoff. Nurse practitioners and pediatric clinical nurse specialists, so yay, the children are represented again, up to $50,000 per provider, okay? The next slide, so that is going to probably be administered by experts in that space, okay? Career Pathways Training Program. This piece we're going to be on the ground much more involved with. So this is designed to build up allied health and other healthcare workforce, and you'll see the titles here, by funding training and education. And the idea is get people in healthcare, get them on a career advancement path, target unemployed individuals. Let's create this pipeline of healthcare workforce. We've been screaming about workforce for years now, and we finally have at least some baby steps to address the shortage. So this is a statewide implementation to career pathways, career advancement and new careers. And the eligible training is going to focus on nursing, professional, technical, and frontline. And you could see the specific titles. They're very targeted based on shortage data that they've collected. Now, the good news about this, and you can move on to the next slide, is they're going to do this through workforce investment organizations. The state is going to contract with 3 across the state. So there's probably going to be 3 regions. And there's going to be oversight for the entire region by each WEO, by each of the 3 WEOs for the Career Pathways Training Program. And the WEO is going to be responsible for coordinating the recruitment, training, supportive services. Very important. We've always talked about social determinants of employment are the same as social determinants of health, are the same as social determinants of education. The successes that we've had in our region when we have implemented our Career Pathways Training Program has shown that wrapping people around with services to ensure that they're successful, food, transportation, childcare, et cetera, is what makes them successful in their education or in their training path to stay in the workforce. So meaningful case management so that they can be successful. The WEOs, there's 5 in our region. So we are not sure if there's going to be a procurement process or if they're just going to designate. We are hoping, FLIPS is a WEO, and we are hoping that we have a good shot at participating and being selected as a WEO. Okay, next slide. And I'm not going to spend too much time on it except for pointing out the red. Okay, and I know you're not supposed to use red font, but we purposely are using red font to point out that this is downstate only, unfortunately. And we had Tommy put together this slide about an hour ago, which shows the map in the counties that are getting these dollars. Great for them. Great for them. But upstate is excluded. This is to support financially distressed safety net hospitals. Just need to point it out. Okay. Next slide, other waiver priorities. And this is what I was talking about before, where we're going to create a slide that shows how the waiver connects to the state budget. Okay. So other priorities are that there needs to be provider rate increases. Okay. So what does that look like? New York State's going to be required to invest at least almost $200 million to increase Medicaid provider rates, fee-for-service, and managed care. All right, so that's not part of the waiver. It's supposed to be part of the budget. Don't ask me how they're going to work that out. We'll get more information as we get it. We'll share it. But at a minimum, we're going to try to show you how the waiver and the budget ties. New York State is going to have to report to CMS, this is a condition of the waiver, what the Medicaid to Medicare fee-for-service provider rate ratio is outside of the waiver. Okay, so regular Medicaid reimbursement, what those rates look like as compared to Medicare. This is going to be something that they're looking at. If the rate is less than 80% of the Medicare rate, New York State's going to have to shore it up by at least 2 percentage points in the ratio of Medicaid to Medicare for each of the services in the service category. All right, both for managed care and for fee-for-service. Okay, so general good news. Okay, but we need to dig in more. I want to start putting together a slide that shows an example of different kind of scenarios so we can show you what the dollar impact might look like. All right, and I'm very interested to know, and this might be something that we talk about in the public comment, I'm interested to know how the accountability will look, okay? How the accountability will look. CMS expects New York State to prioritize primary care, OB, and behavioral health as it relates to this. So we have to do a lot more digging to understand what this is going to look like. Wade has his hand up.
Carol, thank you. And I would just note that as we look at the content on this slide, that one of the attributes of our healthcare ecosystem is that we do not achieve lower cost of care by switching the cost from the commercial program over to the public program or vice versa. And that is a strong feature of our local community that allows the Rochester Miracle to still stand out. And it's an attribute we share with our colleagues to the west of not being the problem here that CMS is aiming towards. And so I just wanted to note, as we go into this work, we continue to be aware of the fact that we enter this work with an awareness of not just our inherent weaknesses and the inequities in our system, but also our inherent strengths and the good places from which we can build. I'm sorry, but thank you for that, Carol.
Thanks, Wade. All right, so we've only got 2 more slides on the other waiver priorities, and then we'll start digging into the HRSN. All right, next slide. 2 more pieces to this. There's a focus on federal funds that New York State received or received for previously non-federally eligible residential SUD services, institutions for mental diseases. Those who are in that space know what that is, so that there's a fuller continuum for evidence-based treatment services with standardized placement criteria focused on the community-based settings. So that is, again, outside of the waiver, but tied to the waiver. Yay, yay, yay. Continuous eligibility for children. Part of the state budget, not included in the waiver, but this is a huge win. And again, I'm going to thank Jeff Kasarowski publicly and Children's Agenda and all the people who are involved in advocating for children across the state. This is the 0 to 6 that you keep hearing about, continuous coverage. So it is tied to the waiver, not inside the waiver. It is outside of the waiver, and it's in the state budget. So continued advocacy for that is going to be essential. All right, last slide on other waiver priorities. We talked about this last time. CMS does want a focus on primary care and alternative payment models. They don't want to recreate the wheel. They want to align everything with already existing models that they're using for Medicare. The AHEAD model downstate, I'm not going to worry about that. Making care primary is our area, and it was released earlier in 2023. A whole bunch of primary care applications went in. It's a Medicare-focused program, but again, CMS, New York State, are trying to mirror what's going on in Medicare and Medicaid, and this is kind of on the path to value-based payment, ultimately for capitation payments for primary care. Definitely not there yet. And the way they're going to do this is through enhanced patient-centered medical home payments. If you recall, I talked about it last time, except last time it was part of the waiver. This time CMS said it's not part of the waiver. You can do this by yourself, state, with your own state budget. Again, not sure how they're going to fund it with the state budget, but CMS said it's not part of the waiver. But you got to do it. All right, but you got to do it. So this is good. Investments in primary care. And the PCMH enhancement is a path to VBP. I think eventually they're going to want to get rid of PCMH and just move everything into more advanced value-based payment for those of you in the primary care space. Okay, now we're going to move into health-related social needs and social care network. Again, I want to start with the money slide. Same slide as before, except the non-essential stuff is grayed out, and I want to focus on the HRSN services and the infrastructure. Okay, so $3.1 billion for HRSN services, and we're going to talk about what that means, and HRSN infrastructure, $500 million. Okay, so just to ground you. Next slide. High level, there are going to be social care network lead entities. They are going to be responsible for social care service delivery through their networks, okay, through their networks, establishing the networks of CBOs, that provide approved HRSN services, and we'll talk about what those are. Greater awareness and access to and coordination among all the entities in the social care ecosystem, and also strengthening the ability for CBOs to provide those services with capacity building and reliable funding streams. Okay, so that's the infrastructure piece. Okay, HRSN social needs, payments, and infrastructure investment. So they need to maintain and strengthen a network of CBOs, delivering high quality, evidence-based, and accessible social care services. Data. Again, effective coordination between social care networks, CBOs, New York State, and other stakeholders, so that we can ultimately prove out that addressing social health-related social needs and providing health-related social needs services impact health outcomes, improves health outcomes. That's the whole point of a demonstration project. Can we improve health outcomes and address health equity and reduce disparities with this demonstration project, with this money that is investing in health-related social needs? And by the way, you can't do that if you don't have a workforce. Okay, so these things are starting to come together. $500 million for the infrastructure piece. All right. Next slide. Social care networks. Couldn't come up with a pretty picture for this. Sorry about that. Really wanting to catalyze the existing assets, the existing work of CBOs. Okay, so we're not recreating the wheel, but we do want to maintain, create a network of contracted CBOs, those with the capacity to screen all Medicaid members for health-related social needs. A lot of you do screening in collaboration with the regional ecosystem partners, healthcare, care management providers, health homes, MCOs, et cetera. How that's all going to be coordinated, we still have to dig into those details, but provide specific social care services to eligible, and I probably need to italicize, eligible Medicaid members to address their health-related social needs. Ensure greater coordination for populations that are identified in the waiver. Again, there's a list. Children, yay. Create an improved and more accessible experience for those who are seeking social care services, and be sure that there's financially and operational sustainability and self-innovated ecosystems that can last beyond the waiver period, waiver amendment period. Okay, the idea is provide more equitable delivery of social care services and address health, racial, ethnic, socioeconomic, and geographic disparities in existing access and quality. All right, a little bit more on screening. The social care lead entities are going to coordinate with the CBOs, as we said, to screen Medicaid members annually. So the idea is all Medicaid members are going to be screened. And the tool that they selected, we talked about this, that we thought that they might select this tool. They did select the Accountable Health Community Screening Tool. Okay. The lead entities are going to be accountable to ensure that there is capacity for this screening. And they're going to be responsible to track the results through their data and IT platforms. We'll talk about that a little bit, to ensure that people get the services that they need. And this is all going to be connected back to the Rio and the Shiny, as Teresa described. Service navigation. All right, so we're going to kind of go deep a little bit here, so stay with me. I know it's, let's see, 3:53. Take another sip of your coffee. These two bullets are in quotes on purpose. I need to understand these better, so that's why I'm putting them in quotes. Following HRSN screening, Medicaid members will be navigated to social care services that most appropriately meet their needs. All right, I can't stand passive voice. Will be navigated. You know, who's going to navigate who, right? So I need specifics on this, and we'll come back and dig in, and we'll do a better job on this slide. Lead entities will be accountable for navigating eligible members to appropriate social care services delivered by CBOs. Okay, those two bullet points need a lot more definition. Using the data and IT platform, the lead entities will be expected to close the loop. So we've heard about this, closed loop referral system. So that's what they mean by the IT and the data and IT platform, and close the loop on the provision of those social care services that are covered by the waiver. Okay, this is not everything. This is that are covered by the waiver, and we're going to have to dive into what's covered by the waiver. The lead entities are going to be instrumental to ensure that this is a seamless process, and there's a focus on member experience. So let's think about the quadruple aim. And I don't know if the quadruple aim is even referenced in this waiver, but the quadruple aim, member and provider experience. And now it's the quintuple aim, health equity, okay? All referral data is going to flow through the platform, supported by the Shiny, again, through the Rio, okay? So ties back to what Teresa had to say. Now we're going to get into the populations who are eligible for these services. Navigation and enhanced HRSN services. Oh, by the way, we are going to be compiling an acronym list that we're going to put on the website because we've got all these new acronyms and it's exhausting, frankly. All right, so HRSN services are targeted to waiver limited population. So they keep saying, you know, they keep limiting, right? Waiver limited, 2 levels of service. Now you're going to notice that if you're reading the waiver and you're reading the Social Care Network RFP, 2 different documents, the waiver talks about level 1 and level 2, and the Social Care Network RFA does not talk about level 1 and level 2, but we kind of just mapped it, and we're just going to say, for all intents and purposes, this is level 1 and level 2, service navigation and enhanced services, okay? The detail around this, as far as the target populations and services, are part of the federally required delivery plan, still has to be worked on. So there's a lot of work that still has to be done between New York State and CMS, okay? We're going to follow that work. We're going to download attachments and figure it all out. The royal we. Okay, level 1 service navigation. This is your traditional screening. Screen, we want everybody screened, whether they're fee for service or managed care, Medicaid. This is all Medicaid. Level 1 case management. This is your traditional navigate to existing services, state, federal, local HRSN programs outside of the waiver to address health-related social needs. Okay, all of the services that are already existing, navigate like you would normally do. We want everybody to be screened. All right, so baseline, everybody gets screened. Whether it's the Social Care Network, the CBO, the MCO, healthcare providers, a lot of people are screening. How that's all going to be reconciled, we have to figure that out. Level 2, and this is where we get into kind of the more detailed, like I said, clinically focused. Members must be in one of the target populations and be individually assessed for medically needing HRSN services on the forthcoming criteria. Keyword, forthcoming, right? But this is the list, right? High utilizers, health home eligible, SUD, SMI, IDD. I'm so glad to see IDD. I was worried about IDD. I'm glad it's in. Pregnant persons, criminal justice is at least in here, except with serious chronic conditions, SUD, Hep C. Juvenile justice, and again, the 2 bullets on children, very happy to see that. Children under the age of 6, children under the age of 18 with 1 or more chronic conditions. So this is really important. Okay, next slide. I'm not going to go through the bullets, but you get an idea about what the level 2 enhanced HRSN services for eligible populations, case management, housing utility support, nutrition, transportation. So remember, we talked about last time that we predicted they were going to narrow the scope. It's not all the social determinants of health. It is case management, not care management, case management. So I don't know what the difference is. We'll have to determine, you know, housing utilities, nutrition, food, and transportation. Okay? And you could read the bullets. We're going to have the slides for you. All right. I'm going to kind of go through, this is the DOH slide, which I thought was pretty good. So we're going to show you how this kind of flows. So screening, everybody's going to get screened, and we're going to get screened for HRSN using this HC tool, right? So they're going to be screening. Members going to be asked, would you like help with your health-related social needs? Okay. So then there's going to be the navigation piece. There's going to be a determination on the eligibility for enhanced services. So either you're going to get your everyday navigation to existing services, federal, state, local, paid for by federal, state, local, right? HHS, county, all the services that thank God we have in our community, right? The other piece is if it is determined that the member is eligible for enhanced services because they have a high risk, you know, chronic disease, all these things that is going to be determined by the state forthcoming, okay, forthcoming, also informed by MCOs having lists, right? MCOs have a lot of data. They know who their high-risk patients are. And the results of the HRSN screening, primary care does a screen, identifies that this person needs food, and it's going to directly impact their diabetes. Mom needs food because it's going to directly impact the birth weight of the child. Those things all have to be determined. The criteria has to be determined. Let's say, yes, eligible for services, referral to the enhanced services. Those enhanced services then are delivered by the CBOs in the social care network. So you can see the flow. Member does not meet the enhanced eligibility criteria, goes to, everyday existing, use what we have in the community. Otherwise, if there is an eligibility criteria met, it goes to enhanced HRSN services. Okay, there's a lot more detail under this, but we chose to not include those slides. We will have probably another webinar where we're going to have to do more of a deep dive on these, so we can add more information and we could supplement it with additional information we get from the state. So I'm going to switch over now to the regions and start talking about the social care network kind of proper and how that's all going to kind of evolve. So if you recall, we showed the map and we were sorely disappointed at how New York State carved up the state originally, right? Remember they were kind of Medicaid rate setting regions, and we're like, what the heck? Our region doesn't operate like that. We operate in a bigger footprint. We have care patterns that go west, east, north, not north, west, east, and south. And we were disappointed that the state wasn't recognizing that. Well, surprise, they did. 14 counties, Finger Lakes region. So that is the Finger Lakes region. And just for reference, Common Ground Health for their HSA medallion and their regional planning are designated and authorized for 9 counties. Flips, we originally had our 13 counties, and Rio has the same 14 counties, just for reference. All right, next slide then shows you what our region is comprised of. Those are the counties. For those are the Rio counties all along the Rochester Rio. For Flips, the additional county is Schuyler. And I was reminded that Schuyler was originally in the Flipped region and somehow ended up in the southern region. So it's back in. Okay, next slide. Another money slide. So this is the same pie. We're only focusing on their HRSN infrastructure. So the bright blue here, the $500 million, the Finger Lakes region allocation, the maximum allocation is $38.6 million for social care network region infrastructure funding. These dollars are going to go from the state to the social care network. And that is going to pay for the capacity building, blah, 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 that I'm going to talk about next. All right, roles and responsibilities of the lead entity. So let's look at the little graphic on the right, and it is from New York State, but I thought it was a good graphic. You've got your Medicaid members. What's that ecosystem look like? All right, on the right, you've got your local government, you've got your social services, your human services, jails and prisons, et cetera. At the top, you've got providers and managed care organizations, right? The Exceluses, Fidelises, Uniteds, MVPs, and the providers and the networks, health homes, IPAs. And then you've got the blue, the CBOs, all the different dots of CBOs, and you've got the social care network lead entity. That circle, that blue circle, is your social care network. So what are they responsible for? Network development, capacity building, fiscal management, data technology, performance management and accountability, operations governance, and coordinating this navigation, the screening, and the referral, and the service delivery. Okay? Next slide. I am not going to go through this. The boxes across the top map back to the previous slide. You can look at this at your leisure, but basically it gives you, there's a lot to do. There is a lot of work to do for the social care network. And it's a big lift, okay? Capacity building, fiscal, there's just a lot to be done in a short period of time, 3 years, okay? So this is the entity that is going to be helping CBOs navigate, understand this waiver, understand what populations are eligible, help them with reimbursement, all of the things. So there's a lot of responsibility in this slide. Okay, so we're gonna move to the next slide, and I know I'm going fast, but we will get these, and we're gonna slow down next time and do more of a deep dive. Let's just look at the other role of this ecosystem. CBOs are gonna be contracted in the blue circle there, and they can screen Medicaid members and do navigation and care management. If they provide those HRSN eligible or enhanced services, they'll be able to provide that. Managed care organizations are going to be contracting with the social care network. So I've said that a couple of times now. Again, PMPM, I've said that before. And they will be providing information to help with the member eligibility question about the HRSN enhanced services. Providers, healthcare providers, BH providers, care management, health homes, they're going to continue delivering their services to the Medicaid members, and they're going to have access to the data that's being collected on the social care network side so that they can also support social care service navigation. So think about it, right? You're going to your primary care, you're getting a referral to the dermatologist. There's no reason why the social care ecosystem cannot work the same way for health-related social needs. Get a referral, you're diabetic, get a referral for food, etc. All of that system can be replicated through the Rio, through these data platforms. Same concept. Your data is getting exchanged. There's going to be a whole privacy and all that, that's going to have to be worked out, opt out, all of that. But the idea is to integrate social care with healthcare and vice versa. And this is baby steps again. This isn't all social determinants of health. This is screening so we understand a baseline. And then we're able to identify what are those things that are going to help people with their clinical outcomes for these health-related social needs. So it is scoped. It's targeted and scoped, which is what we thought was going to happen. All right, next slide, social care network partnerships. So the social care networks are going to coordinate with regional entities. They're going to demonstrate an understanding of different stakeholders and potential partnership, leveraging existing relationships. This is a very strong relationship-based model. So what's great about our community and our region is we've got really strong relationships. So we need to leverage that. Partnerships across all of the broader social care supports as well, and then leverage existing partnerships or develop new partnerships with managed care organizations, providers, and other agencies and jails, etc. Okay. Requirements. Now this is getting into the weeds, and I, debated whether to include this. We pulled out a bunch of slides. We'll include them later, but I just wanted to give you an idea of the requirements for CBO participation in the social care network. We gotta be able to provide navigation navigation services or one of the enhanced health-related social needs, maintain the coverage area with the zip codes in the region, so those 14 counties, not-for-profit status, designate who you're gonna have as your designated person for the social care network data technology requirements, and validating the accuracy of the information. Demonstrate cultural and linguistic competency. I'm really excited to see that. This is a really important piece that speaks to the CBOs as trusted brokers in the community. Committed to accepting referrals and providing services and collaborating with social care networks and other stakeholders to coordinate the delivery of services. And they can access or project potential capacity constraints. Capacity is going to be a real issue here. There's going to be all that screening going on, and all these people who are floating to the top that need health-related social needs. We need the capacity to be able to deliver those services. Again, back to workforce and back to capacity building for CBOs to be able to handle the incoming volume for that target population who need those services. Okay, it's not gonna be everybody, but the target population. There needs to be management of capacity and understanding of capacity. Okay, next slide, data and IT infrastructure. Not to repeat too much, but the data platform is gonna have to enable screening and navigation, track network management, fiscal management. There will be other partners who also will be using that infrastructure and sharing data so that there's evaluation, program evaluation, and impact program evaluation. Referral will flow through the data platform supported by the Shiny. We've said that 4 times now. May use new or existing or new data platform. There is going to be a whole thing about what the requirements for that are. There's going to be a requirement to, be able to qualify to have a platform as part of the social care network. So that's going to be part of the RFA. They have to conduct due diligence with any subcontractors, partnerships with other SCNs or MCOs might need to happen. And the social care networks might need to use infrastructure dollars to support the development of their platform, setup, implementation, etc. And then there's existing platforms as well. So that's the idea. All right, eligibility for the social care network application. All right, this isn't going to be like 1 million people. This is going to be a couple of entities, theoretically, who would be applying for this so that they can leverage their existing infrastructure and network. 501c3, that the possibilities of who can do this is pretty broad. Community-based organizations, IPAs, health homes, BH, to be the lead, federally qualified health centers or PPSs. At least 3 years experience working with CBOs, contracting and fiscal administration, leading CBOs within a network, convening, coalition, other organized group, leading care management with partners, including CBOs. Those are going to be all sorts of criteria, okay? Okay, there's a lot more detail on this, but I'm going to talk about the timeline for the social care networks, okay? Those networks that are going to be interested in applying. Again, it's a turnaround that's very quick. There's going to be, there was a conference yesterday where DOH provided information. We turned around a lot of that information in these slides, so it's fresh. We don't have a copy of the actual slides yet. We actually took screenshots. So if there's anybody from the state on this call, I apologize in advance. I did not specifically ask for permission, so hopefully I'll be forgiven. Questions are due by January 31st. We're going to help compile that as a community. On or about 2/9, there'll be answers posted, and then due date 3/27 by 4 p.m. for the applications. So again, you're going to be looking to your networks or your affiliations and understanding which partners are going to be interested in applying for this. Okay. Next slide. Governance. The lead entity is going to have a very specific governing body. So CBOs with at least 1 service location in the region. CBOs represent 51% of the members and have majority share in voting rights. Healthcare and care management partners can be part of this as well. At least one provider from mental health and substance use, community advocates, and at least 2 Medicaid members themselves who have health-related social needs. So the governance is pretty specific. It is, I think, nicely distributed with a lot of power to the CBO. So that's great. I'm going to go quickly here on 3 sources of funding for the social care networks. It's kind of 3 buckets. Infrastructure funding, which we talked about, that slice, remember, that small slice. Health-related social needs screening and services payment, that is that big bright blue slice. And then performance-based bonus payments. There is an upside risk element. So infrastructure funding, again, is to fund startup costs, infrastructure IT capacity building. Then there's payment for direct services, screening, the enhanced HRSN services, right? The level 1 and level 2 that we talked about, ongoing reasonable costs for service delivery, right? Claims processing, blah, blah, blah. And then that is going to be done by a PMPM. We talked about that, from the managed care organization to the social care network. And then again, the services are going to be paid for on a fee-for-service basis to the CBOs on state designated rates. Performance-based bonus payments, again, upside risk. Theoretically, social care networks will work with managed care organizations to get involved in VBP with upside risk. All right, I'm going to start moving faster because I know it's 4:14. Infrastructure investment, CBO capacity building. The social care network lead is going to be working on the capacity building. Theoretically, this is like leveraging all the assets we have in the community, all the expertise and all the experts to help CBOs with their capacity building, that infrastructure slice of dollars. Things that can be done is to support workforce, enrolling in the platform, training for screening, supporting the data sharing that has to happen, technical assistance. Really want to get the CBOs ready and able and get them the support that they need so that they can participate in this work. Lead entities then, of course, have to do reporting. There's going to be a heavy lift for reporting to New York State, and the social care network is going to have to coordinate that. Next slide. Health-related social needs payment. Okay, so that was the infrastructure slice, and I know some of this is repetitive, but hopefully you're getting the idea here. That was the infrastructure slice. This is, again, the bigger slice that relates to, that darker blue. New York State, again, is going to flow funds to managed care organizations for screenings and service, enhanced HRSN services. New York State is going to also flow funds directly to the social care networks for the infrastructure and capacity building, right? That small slice and bonus. That's where the bonus is. MCOs are going to pay the lead entity, the PMPM, for these screenings. I probably should have put that bullet up closer to the top. Social care entities are going to pay CBOs set rates. So I said that, fee for service. And then interestingly, the social care entity is going to generate a social care claim for that service up to the managed care organizations as an encounter. So those of you in the healthcare field, you understand that there's an encounter model where you submit a claim, but there's no payment because you already got the PMPM. The social care network already got the PMPM. The social care network paid for the fee for service, but the claim needs to go to the managed care organization so they can reconcile everything on the back end. Okay? So those are the words that describe the next picture. So some of you follow the words, some of you follow the picture. So I wanted to show it two different ways. This is a graphic from the state slide, which I thought was really good. So New York State, as you can see, provides infrastructure funding, follow the purple, infrastructure funding for the lead. And then the managed care organization provides dollars, PMPM, to follow the number 2, to the social care entity. Number 3, also bonus payments. And then the social care entity provides the CBO payment for services on a fee-for-service basis. So if I were to redo the slide, I would put next to number 2, HRS and screening and service payments, I would put PMPM next to that. And then number 4, I would put fee-for-service next to that. That's not my slide. Okay. That was a lot. I know that was a lot. And so I'm going to go back to the future, what we talked about last time. How can you prepare? So it's a similar kind of message that we've had last time. Little bit different, but similar. What networks are you part of? What IPAs are you part of? Are you part of social care networks? Who are your partners? What are your referral patterns? Do you need to create new partnerships? Are you even interested in this at all, right? Do you do screening? Do you provide enhanced HRSN services? We're going to provide much more information on this. Do you conduct the screening and provide the services as it relates to the health-related social needs? And then on the workforce side, look at that list. Do you have any of those roles in your organization? Do you have any clients who might be interested in a healthcare career pathway? All right, we're going to need to know that person. We need a referral from our own community to get people involved in the healthcare workforce and into a career pathway. Or are you an organization that provides workforce development programming that should be part of the WEO Workforce Investment Organization ecosystem that can participate, and so we can leverage all the assets that we have in the community around workforce. Okay, this is the slide that I did not change. I think this is pretty much the same, except instead of providing social determinants of health services, we changed it to HRSN. What's your capacity? If you do provide it, what's your capacity? How do you collect data? What do you do with the data to inform what you do and how you work? How do you measure the impact? I mean, all of this eventually is to prove out the value of health-related social needs. So eventually, there's going to be a need to look and see what the value of your particular services are. I mean, right now, the way that it looks, the state's going to set those fees, all right? But in the future, under VBP, there's going to be the importance placed on what is the value of your services. They're going to be asking, if I contract with you, what am I getting in return? Am I getting better diabetes outcomes? Am I getting better equity? Am I addressing disparities? The people who are paying, right, the state, the NCOs, the employers are going to be looking for the value, the ROI. And that's just, that's kind of the black and white finance aspect to it, but that's an opportunity. It's an opportunity to show your value. So that means you need to know what your cost structure is, right? Is it even worth you getting involved in this or translating what you're already doing to participate in this? Do the services you provide keep people in the community, improve outcomes? Understand how VBP eventually can apply, a little bit later on. But, we talk about VBP a lot, but, we're getting a little bit more comfortable with the notion of VBP. And theoretically, this should all lead to VBP because as the risk and as the dollars move closer to the providers, not just healthcare, right? Providers, social care and healthcare providers have more control over what they do with that dollar because they know what is right for the patient. They know what is right so that there are improved outcomes. Okay, that was a lot. Next step. We're going to continue to review the details of the waiver and the RFA. Both documents are on the website. The waiver, I think, is 239 pages. The Social Care Network RFA is 60, 80 something. There are going to be additional attachments that we have to download that we have to sift through. We're following all the New York State DOH webinars, notices, FAQs. We're going to create our own. We're going to combine them. Hopefully, we're going to determine soon, once we get more information, what the next webinar might look like, a deeper dive. Not sure if it's going to be a deeper dive, on the RIO work or on the SCN work or on the definitions or on the eligibility criteria. We're going to kind of be flexible and see what happens, and you're going to have to give us a little grace. Okay, so this is, again, flying the airplane as we're building it again. Okay, next slide, resources. There you go. We've got the newsletter and the website. Just go. If you don't get the newsletter, sign up. We're going to try our best to keep people informed now that things are happening. And let's see, 422. I am sure that the Q&A is blowing up. It's not popping up for me, so they spared me that. But I'm hoping that there's some activity going on. And Albert, well, first of all, Wade, I'm going to let you say a few words. I'm giving you 1 minute. I'm telling you right now, 1 minute. And then I'm going to let Albert.
Carol, I'll use that 1 minute quickly and say, guys, I have been devouring tons of material on the waiver and the governor's budget, and I recognize the density of what we just shared with you, but trust me, the best doggone presentation of current state that I have seen and heard. Carol, thank you very much. I know how much work went into this, and we appreciate you. I would say, given that, however, please pay attention to the fact that Carol was right. There is much we still don't know. And as we learn more, we will share it. We will repeat this type of learning opportunity, but it really requires you guys to please keep your cards and letters coming. Let us know what you need to know and let us know what we don't know. I have to admit, I've been in this business since 2006. I'd not heard of community care hubs, but thank you all for bringing them to my lexicon. And this is the way we're going to build this, by us doing it together. 3 more Post-its to go and I'm done. The good news, my friends, is that we are so ahead of everybody else, not only in the doggone state, but in the nation. Marlene and I were at a Civitas conversation following up on a kick presentation that Teresa and Holly and other members of our team gave at Civitas. We are leading the country in terms of thinking about how we actually use data that speaks honestly to equity to make a change. We still have to figure out how to do it, but let us celebrate. At least we are purposing in this direction, and that's a major change than where we were when I came into public life back in 1984. Let me also say, with post-it next to last, please keep in mind, this is not about the waiver. The waiver is a vehicle. It is the means to an end. And the slide Carol pointed out about how we demonstrate value to have the healthcare system pay for the right care at the right time in the right place is what we're aiming for, and we will not get there without your help. So please keep sending us your queries. And my final post-it is the greatest handoff to Albert. We will be back, and we will, because of Albert and Janet and the whole team's hard work, get answers to your questions back out to our growing FAQ, which really stands out as a best practice that other communities had not done but are now mimicking. Thank you very much, Carol. Excellently well done.
Great. Thank you, Wade. I think that was more than a minute. Somebody's going to time next time. All right, Albert. How about, I'm going to put you on the spot, general themes, which I think I can anticipate, but general themes?
Yeah, so first of all, I'll say that we are with an incredibly informed crew. These questions are in the weeds, in the detail, and looking for answers to things that I think we're also looking for answers for in a lot of cases. And I also, want to tee up Janet as well, without whom I don't think we would have had as many great answers to some of these questions. But I think folks are really concerned about how all the connections are going to be made between the SCNs and the CBOs and the MCOs and what all that's going to look like and the details behind that. It also seems that there's an interest in making sure that the funding is there for the infrastructure that folks are going to need, especially from the CBO side, to be able to execute. And that means IT resources, security resources, financing resources, those types of things as well. I would just say that like I said, there are a lot of questions in here that we don't even have the answers to yet, but we'll be working to get them to you. And with that, I just want to invite Janet. What did I miss?
No, you got it. I think that there were, as you said, some great questions from everyone. And, even on performance of, like who grades the performance of the SCN. And, right now we know it's DOH, but a lot of it's still being established. And, I'm so excited for this work. I just got to say, I think this was the work that we've all been waiting for over the last several years of Medicaid reform. And, we appreciate the opportunity to present this to everyone. And, we'll do our best to put together the answers for you and be a resource for you.
All right. Thanks, Albert. Thanks, Janet. So to cap it off, I really think we have a great opportunity in our region. We have a lot of assets. We've got good infrastructure. We need more investment in infrastructure. We've got great experts. Hopefully we can come up with a collaborative model for our region and work together and really maximize, optimize this opportunity. As Wade said, this is a tool, this is baby steps, but we don't want to miss this opportunity to make a difference. It's not exactly what we wanted, but it's something. And it's approved, and we're going to jump on it as a region. So excited to have you, and thanks for sticking with us. It's 4:28. I can brag that I finished in 2 minutes to spare. Have a great evening, everybody.